Hi, today we have with us Dr. M.J.Arunkumar, the Director of Neurosurgery and Neurosciences at Hannah Joseph Hospital, Madurai. He is also an alumnus of CMC Vellore. Doctor, having been in this industry for over 30 years, what is the most common type of brain tumor that you encounter in your practice?
Brain tumors are basically classified into benign tumors and malignant tumors. The benign is otherwise called as a non-cancerous tumor, and the malignant tumor is called the cancerous tumors. So these are the two types we encounter, under which we have many subtypes. Among the benign tumors we have meningiomas, craniopharyngiomas, pituitary-adenomas, and these are a lot of these types in benign tumors because these doesn't really have any issues in the longevity of the patient's lifespan of the patient. However, the cancerous types, the most common and the most dangerous one is a glioblastoma. Those are the kind of ones which is really makes people suffer and their lifespan drastically comes down. So these are the kind of tumors which is we encounter about in daily practice in neurosurgery.
Is headache a common symptom, doctor, of a brain tumor?
See, a lot of people have headache as a symptom. Everybody comes, majority we see in the clinic, you see OP, you around 8 to 10 of them are people who have headache. But this headache is something very specific for brain tumors. You have very intense headache, especially in the bifrontal, that means the front of the head, sometimes in the back of the head, coming to the orbits, the eye. And this headache is sort of very severe on waking up in the morning.
Okay.
On waking up in the morning, you see very severe headache, and vomiting relieves headache.
Okay.
So headache associated with vomiting, and vomiting relieving the headache is a classical sign of a brain tumor. So that is really needs attention. Okay. And I think patients who have such problems should go to the neurologist or neurosurgeon and address his concerns so that they can go for further investigation on this.
Okay. And usually does it just go away by popping in a pill, the headache just disappears, or does it stay in case of brain tumors?
See, there is difference between the brain tumor and migraine. Okay. See, migraine and I think the stress-related tension headache, stress headache, all this comes late in the evening. Okay. It's about late in the evening, you come back from work, come back from school, many people have this kind of headache which is migrainous.
Okay.
Whereas headache, the headache which is associated with brain tumors is always classical, waking up in the morning. Okay. For which usually they try taking some paracetamol or some analgesics, but doesn't relieve at all. Right. And if you see in the next couple of days, in a few days, and this analgesics doesn't give you good relief, then I think you must go for sorting a consultation with the doctor and see the further investigations are initiated. Right. You can't sit on it and wait. Say it's just a vascular headache. Correct. Or it's just another migraine. Correct. And it's because I had a fight with my colleague somewhere, so I got very tensed up, and therefore this headache come. Right. You can't do that. You can't say that. Yeah.
Right. What other symptoms should I look out for if I'm suspecting a brain tumor, doctor?
Apart from headache, you can have sometimes the patient can have some drowsiness. Sometimes if it's involving the tumor is involving the speech areas, they can have problems with speech, language dysfunction, arithmetics, not able to write properly. These and signs of all this mentation, problems with the cognition, all this can happen. Okay. Some people develop visual symptoms, very common, the visual symptoms, blurring of vision, double vision is very, very common. And going on from there, some of them have chewing difficulties, hearing problems, and giddiness. All this can come. Apart from this, if there are very large tumors involving the brain on one side, you can have paralysis on the opposite side. You can have numbness, you can have weakness or paralysis, which can be progressive. In case of benign tumors, it is very, very slow. In fact, sometimes it takes many months to years to progress to give you symptoms of weakness or numbness. However, if the patient has a very malignant tumor, it's very malignant, like glioblastomas, there are some of these very dangerous tumors in the brain, and sometimes in children also. I say in children also, we see most of the children, they have this tumors is mostly malignant, unfortunately, and they have a very rapid course. For them, the headache comes, the weakness comes, it progresses very fast. And also, once this progresses very fast, they also have difficulty in walking and balancing, like they lose balance. They even can't balance with their hand also. Apart from walking, they have difficulties holding on to glass to drink water or coffee. They keep spilling. So these are all things which how the other symptoms and things appear as the disease progress.
Doctor, between adults and children, is there any difference in the incidence of brain tumors?
In people who are actually more than 60 to 65 years of age, once you cross that, the chance of brain tumors, especially malignancy, which is very high on the cards.
Okay.
The more the age, they tend to get they get affected by these kind of tumors very often, and they really need to watch out if whatever symptoms and signs which I told you now, if these involves the neurological deficits, then they had to seek medical attention. In children less than 15 years of age, brain tumors are very common. Especially, unfortunately, as I'm saying it again, that in the younger age group, the more of malignant brain tumor comes when compared to the benign ones.
That's very sad.
And it's a sad thing that, like it happened several times. I've seen very small children who are just 2 years old, 3 years old, 4 years, who come with a very disastrous tumor called medulloblastoma. These are all very highly malignant tumors. They are all called the grade 4 tumors. Children, it's a medulloblastoma, sometimes glioblastoma comes. Similarly, in adults, you have glioblastoma, which is again grade 4 tumors. And their survival rate and prognosis is pretty poor. Sometimes they have a survival rate around 12 to 18 months, sometimes even lesser. The more aggressive the tumor, whether it's adult or the pediatric age group, the tumor per se is aggressive, the longevity and the lifespan becomes shorter.
But how can somebody say the difference between a developmental abnormality or aging process and the symptoms of brain tumor, doctor? Is there a way for them to find out that this is because of brain tumor, not because of aging or a developmental abnormality in children?
No, I don't think it's anything very connected with developmental anomalies, developmental retardations with brain tumors in children. It's totally different, but actually it has a genetic pattern to it. Sometimes it can be carried on. The grandfather, my grandmother may have a brain tumor, and it can be transmitted to the offspring, maybe the third generation, the grandson or the granddaughter. It has a genetic code to it.
Oh.
But it's nothing connected with the developmental anomalies, but these are more of in the family. It runs in the gene. It can be transmitted like that. That is very sad, You're tracing out the history, you will find they'll say the child is here, the grandfather died of brain tumor. Mm-hmm. Or sometimes they say even the grandmother or somebody, the grandparent, one of them had died of a stroke. Something related to the neurological symptoms, not just brain tumor. Mm-hmm. It may be even stroke or something related to the brain.
Doctor, on suspecting brain tumor, what are the possible tests that someone can undergo to confirm the diagnosis?
Earlier, we had the mainstay was CT scan. They had to do a plain and contrast scan also. But nowadays, this sort of CT scans have become mainly in use in trauma, in accidents and emergencies, or for check CTs. Now the main thing is we put patients to do MRI scan. The MRI scan with contrast has to be done. And we also have something called MR spectroscopy, where if you think this is a benign tumor, then we can stop with the contrast scan. And sometimes we need MR angiography and sometimes venography. Even if it's a benign tumor, it may be very vascular. So you may need an angiogram to find out how vascular it is, or it may be obstructing some venous sinuses. Mm-hmm. So we have what is called the MRI brain with MR angiogram, venogram, and also the MRI brain with contrast. However, if you suspect, if you're going in thinking of malignancy, we also add one more spectrum to it called the MR spectroscopy. Okay. The MR spectroscopy detects certain the malignancy, the malignant part, the grading part, whether it's highly malignant or less malignant, based on the metabolites. It's something called the choline, lactate, lipids, and N-acetyl aspartate. These are things for the medical people, but based on this, we can diagnose how severe the tumor is, what kind of a grading the patient will have, based on the MR spectroscopy. It is very, very important. Apart from doing a routine MR brain with the contrast, you also ask your radiologists. I mean, they will definitely do that MR spectroscopy once they suspect a highly malignant tumor. Apart from that, if you are suspecting a metastasis, meaning what is the metastasis? The metastatic tumor to the brain, that means this tumor originating from somewhere else in the body. The primary malignancy is somewhere else in the body.
Okay.
And this tumor is seeded through the bloodstream and is reached the brain. This usually happens in certain type of tumors. You see on the MRI scan, you find certain tumors. It's something, it's medical, of course, neurosurgical and neuroradiological. You suspect something like a metastasis, also called a secondary brain tumors. Then we can go in for the PET-CT scan. The PET-CT scan will detect if there are any tumors elsewhere in the body.
Okay.
See, we had recently also some patients who had something like a secondary, so we had to go for a PET scan, and the PET scan detected a tumor in the thyroid. She never had a thyroid problem before, never ever had it. The first time she presented is only by headache and vomiting and some giddiness, and you find a brain tumor sitting there. And finally, when you did the PET scan, you find the primary is sitting in the thyroid. So these are the present scanners, diagnostic kits one needs to use for detecting a brain tumor.
How common are these facilities in India?
I think almost all cities and tier 2 towns and tier 2 cities, all of them have these facilities.
Okay.
Almost. PET scan is also all metro cities, they already have all these facilities.
Okay.
But now even a PET scan is available in a tier 2 city, and a tier 3 cities also having MRI scan with all the facilities.
Okay.
So detection is no problem. We keep seeing scans or MRIs done in every district headquarters hospital also has this facility where they do the scan there, the MRI there, and then they refer the patient over here for the surgery. So everywhere the facilities are there. Only thing is, you need to identify who the particular patient is and then go for your scanners.
So is there any technique for an early detection of the condition?
It's very unlikely to have any detection in the early stages because there's no specific things like any markers or anything that's available like in other areas, other organs of the body. But there are some associated features. Like, for example, there is a condition called the neurofibromatosis.
Okay.
In this condition, you'll find the cafe au lait spots. You'll see some brownish skin patches.
Okay.
Brownish skin patches, they call this cafe au lait spots. And they can also have subcutaneous nodules. You'll find a lot of people having subcutaneous nodules in their face, hand.
Right.
This is a neurofibromatosis. It's called a neurofibromatosis. These patients are, again, when you see this in a patient, he can be linked in the present or in the future to having a brain tumor.
Okay.
For example, there's something called optic nerve gliomas. There's something called the vestibular schwannomas.
Okay.
All these are brain tumors, sometimes in the spinal cord. There may be spinal cord tumors associated with neurofibromatosis.
Okay.
So these are associated medical conditions which can also have brain tumors. Not that I'm saying that every patient who is having the subcutaneous nodules and cafe au lait spot go and scan themselves. No.
Okay.
Only if they have a symptom.
Okay.
When they have symptoms of raised intracranial tension or headache or the symptoms which we all described, then they go for the scanner. And when you go for a scanner, always when you do this for this particular group, when you see a scan, you do the MRI scan of the brain, you also do screening of the spine, the entire spine, to pick up some nodule somewhere. The same nodule may be sitting in the brain, and some of the nodules are sitting in the spinal cord also. So that is very important to identify that.
So doctor, what are the treatment options available for brain tumors in India and elsewhere?
See, for brain tumors, we have the regular surgeries, microsurgery, and then using the microscope. We have advanced microscopes in the country. Then we have this endoscopic tumor surgeries, where specifically in some of those deep-seated lesions where inside the ventricles and those areas we can use endoscopic surgeries. And sometimes we have the microscope assist endoscope.
Okay.
You can do the microscopic surgeries. Some places where the microscope could not reach, you can go for endoscope also. So most of the centers, they have both.
Okay.
They have the microscope, they have the endoscope. So it is like various gadgets they have. So you can use appropriate gadgets to use for any kind of tumors. Apart from that, the recent trend is like the last 10 years. More and more we have started having to get the navigation guided surgeries.
Okay.
Navigation is very precise. It's like how a GPS system works. You go to the Google map and choose a place, and then you want to go to KFC or any place. Like it will take you to the place.
Okay.
Similarly, the navigation also, it will guide you. It will guide the surgeon to go to the right place and get the thing done.
Right. Okay.
In certain areas, not for all cases you need navigation, but in certain cases you will need navigation. And also, we have this kind of a deep-seated lesion. Sometimes the tumor may be very, very far away from the surface, maybe at a very depth. In that case, we need just a biopsy, and we have stereotactic biopsies.
Okay.
And it's been very common those days. Stereotactic biopsies are very, very common, to take a biopsy of the tumor, send it for histopathology, meaning the reports will come to assess whether it's benign or malignant, and further you can go in for the rest of the treatment like the radiation and chemotherapy. Apart from that, we also have fluorescence guided. Fluorescence guided meaning like it's a dye.
Okay.
You can inject the dye and you can see the yellow fluorescence. You also have the 5-ALA and many things are there. And they will, these dyes will go and brilliantly illuminate the tumor.
Okay.
So we have special filters guided by IR rays, and with the special filters in the microscope, you can identify tumor from the normal brain. So those are things which are coming to recent thing, and we have quite a lot of centers in this country, our country, who do fluorescent guided surgeries, navigation guided surgeries. So we are more precise to take out the tumor.
Right.
So these are things which has come in the last, maybe in the last 10 years to our country. And many centers are using it with good success rate. Yeah.
And doctor, most of the surgeries that you're talking about, a common doubt that most people have is, will it all involve opening of the skull, or are there any other minimally invasive techniques?
See, some of those tumors are just under the skull. Like for example, the surface tumors. It's all on the surface, pressing onto the brain, like meningiomas, very common.
Got it.
For that, you need to open the skull at that area to remove the tumors. I think this is the common thing practiced elsewhere in the world, all over the world they practice. Whereas some of the deeper seated lesions, sometimes it is inside the brain, this deeper seated lesions, there are various techniques. I said using about endoscopy is minimally invasive. Then about navigation guided surgeries. You need to open the skull, but in a very small area, so you minimize the skull opening.
Right.
And in case like an endoscopic surgery, you just need a little bird hole or a small incision and a thing where we can go. But the problem is endoscopy cannot be used for everything.
Right.
But endoscopic surgery has become a big thing in all the skull-based approaches, especially in the pituitary adenomas, craniopharyngiomas. These are all done through the nose, endoscopically. All the skull-based, extended skull-based, those approaches have been done now almost many centers in this country.
Okay.
So those things where endoscopy is come into very much of a prominence, and it's been adopted by almost every city have these centers where they can get to do this minimally invasive surgeries.
That's quite a relief.
Yes, it makes like no opening of the skull. In those days, we used to have 25 years back and all. We used to have the microsurgeries for pituitary adenomas, transept. That was through the nose only. But now endoscope is taken over, and it can reach into many components, many areas, or many areas can be well visualized.
Okay.
It gives a very panoramic view of the skull base, the tumor area.
Okay.
And on top of the skull and other tumors, it also has an assisted aid. Apart from doing with the microscope, there's so many terms, all technical terms, which only the neurosurgeon can understand. But I just to people, I just say is everything is available in our country.
Right.
We have much. 10 years ago, 15 years ago. Now we reached a different level almost. It is the reach of the normal public now.
It's very understandable because a lot of international patients have started flying into India for availing a lot of these services. So it's very evident that India is pretty advanced.
A lot of international patients are also coming to India because because the wait list is less. In the international arena, like UK and other European countries, especially where the waiting list is more, they fly down to India, get operated, and go back.
Right.
The second is the cost. The cost is much, much less in India when compared to the other countries. Either it's controlled by the euro or the US dollars. It's much cheaper here. And of course, there are good facilities, good air connectivity is there. All this making people shift from other countries to India to get surgery done here.
And we have some of the finest hands like you in India, so I think that's another feather to the hat.
We have very good surgeons in India. Our country has produced one of the very good surgeons in the worldwide. Almost all metro cities and even the smaller cities. Everywhere there are good neurosurgeons. Indian neurosurgeons, I don't think they're second to anyone in the world. Yeah.
So how safe are these surgeries, doctor? And could you also throw some light on the complications that could arise from such surgeries?
Yeah, now I think with the advancement in all the techniques, with the gadgets and the neuroanesthesiology, the anesthetic agents, the advancement in anesthesia, it has become quite relatively safe. For majority of tumors, it looks like the risk factors are around 2 to 5%. It's worldwide the same thing, and most of our Indian scenario also is very, very similar. Majority, 90-95%, nothing happens to the patient. They all come out very well.
Okay.
There are certain kind of tumors in very difficult locations, like in the skull base or in the deeper part of the brain, like the brain stem, and sometimes which involves vessels, the vessels that arteries and veins that supply the brain and takes the blood from the brain to the heart, the venous channels. Sometimes these tumors involve those areas. The risk goes a little higher. But definitely the anesthesiology, the anesthetic agents and everything, it's become much better, much better. Not like what has been seen in the last 20 years back, what it is, and now today's scenario is totally different. So you don't have to worry about that kind of complications so much. Yeah.
Does this end with just the surgery, or will they need further follow-up treatments like radiation or chemotherapy like in the other kinds of tumors?
These patients who undergo surgery, there are both the benign or the non-cancerous and the cancerous types. The cancerous tumors or the malignant tumors, definitely, even if you remove surgically, you do a radical excision, meaning like you completely remove tumor. There are a lot of this spread in the minor roots. They say in a layman term is called a roots or infiltration. You will need radiation therapy, and depending on the grade, we have chemotherapy, and the latest form of therapies now it has come all over the world is what is called immunotherapy.
Okay.
It's very expensive, but the immunotherapy is coming out, gene therapy and all this using the monoclonal antibodies. It is coming in a very big way.
Right.
So I hope that in the future the pricing of this can come down. It can come down. But if it's a very highly malignant tumor, all this can increase your longevity. I won't say in high-grade tumors is a complete cure is possible because it tend to recur. Very few reports in the world say that some of those highly malignant tumor still surviving for 5 years, 10 years and all those things, but they're very, very unusual. The highly malignant tumor with the surgery, with the radiation therapy, chemotherapy, and if at all this immunotherapy, you can, for example, a glioblastoma, commonly they say survival is around 12 months to 18 months. Okay. There's another category, benign tumors like meningiomas, pituitary adenomas, craniopharyngiomas, all this, even the benign tumors, where the surgeon is not able to completely remove it, because certain times you'll find it's in a place where it may be involving the skull base, the bones, infiltration bones, or the vessels, like the dural sinuses, or some complex area. Though it may be benign, it may not be completely accessible. So for that, you need to give additional radiation therapy so that it doesn't regrow. For very common in pituitary tumors, the pituitary is very, very common almost everywhere, as you can see. Sometimes it involves the sinuses, the vessels. Some try to open them into the vessels and try to take it, but it causes additional morbidity. So a lot of people, a lot of surgeons, to be on the safer side, they go for radiotherapy. And radiotherapy has also become very good and very safe nowadays with the advent of a lot of advancement in the IMRT, IGRT. Then fractionated radiation is called stereotactic radiotherapy, the stereotactic radiosurgery, which is also useful, very useful in treating benign tumors, the leftover or the residual benign tumors. I would say people should not get that idea of, all tumors are Or, okay, it's a cancerous tumor. Okay, I am willing to go for radiation therapy and other things. But the benign tumor is not that you'll be able to completely remove it always.
Okay.
Yes, of course, 90-95% of the times they always can easily remove it. But when it involves the blood vessels, when it involves the dural sinuses and important areas, sometimes these benign tumors may be sitting in the skull base, involving the bone and some crevices. Those parts which is not accessible, even with the microscope, even with the endoscope, or the surgeon finds this is going to be too complex to remove that part, is going to be at a risk of life of a patient, he will say he will stop. And then he will go for radiation therapy. This is as good as that. That's a very good practice, and that is acceptable. Worldwide is acceptable, that's what I'm saying.
And generally, how long do these treatments span?
See, if it's a conventional radiation therapy following a malignant tumor, whether it's adult or children, they go in for fractionated radiations for around 5 weeks. 5 weeks or 30 days. With usually every week they have a break of 1 or 2 days between. But however, the benign tumor, the amount of the dosages are much less. They can have the SRS, meaning like the stereotactic radiosurgery, which is just one sitting or maximum 3 sittings, or the fractionated therapies which last for 5 or 7 sittings. That will be enough for these kind of the residual benign tumors. So you don't have to worry about it, and sometimes even with all this therapy, some of the tumors recur. Especially the malignant tumors recur, they spread out to the brain. At that time, it is very difficult to control. However, if it's a benign tumor, sometimes they recur back after a couple of years, sometimes even very short, in which cases sometimes resurgery may also be indicated.
Right. Yes. Okay. Doctor, following all modalities of treatment that you're talking about, how soon can somebody return to normalcy or resume a normal life?
Yeah, see, if it's a benign tumor and is adequately removed, and subsequently doesn't need any radiation therapy for any residue, I think earlier, maybe in 2 to 4 weeks' time, they can go back to their work, office work, or any kind of normal work, which doesn't involve any very heavy, rigorous kind of exercises and kind of thing. Whereas in malignancy or patients who are undergoing radiation therapy, you need to postpone for a month or 2 until the radiation therapy gets over and controlled. Then they need to follow up on radiation, and chemotherapy is there. So depending on what type of work you do. Because I remember some patients who had been back to the work even abroad, and they continued to do the work. And even in case of malignancy, they continued the chemotherapy in the other country, and then they used to come for follow-up once in 6 months, or 3 months, or 6 months or so, and ultimately he had a recurrence at the end of 2-3 years, so they had to come back, and then that is for malignant tumor. But of course, benign tumor, you can, if in case even after radiation therapy, you just wait for 2 weeks, you feel fine, you feel good, and especially in the radiation therapy time, whatever therapy, you see that you are hydrated very well. You do hydrated very well, drink a lot of water, and you feel fine, you go back to work. I think it's within 2 weeks to 4 weeks, you can easily go back to work. Yes.
Doctor, thank you so much for having taken time off your busy schedule, and thanks for throwing so much light on the incidents, the treatment options, recovery, and all those details pertaining to brain tumors. I'm very sure that the public will benefit at large from the kind of educational information that you have given out today. Thank you so much once again.
Thank you.